for part 1, part 2, and part 3 of the quiz. I will remind you that in part 1 we talked about ventilation. So in part 1 we talked about ventilation and dead space ventilation and so forth. In part 2 we talked about diffusion. So diffusion of gases across the alveolar capillary membrane. Yeah, if you know how to do it, I always just wait for it to go away by itself.
It went away.
Yeah, I think you have to go to HDMI 4 and then just give it time, and that'll go away. Okay,
There you go.
that's an improvement.
There you go.
Thank you very much, Ed. Ed spends a lot of time with the remote at home. So the first presentation, way back when, we talked about ventilation and dead space ventilation and so forth. And then in the second presentation, we talked about diffusion across the alveolar capillary membrane. In the presentation that we did last month, we talked about blood flow through the lungs and the physiology of blood flow through the lungs and pulmonary hypertension. Today, the fourth presentation, we will talk about gas exchange, and specifically we will talk primarily about the physiologic causes of hypoxemia. So our objectives are to list the causes of hypoxemia, to use the alveolar gas equation to calculate the alveolar PO2, to explain why shunt is poorly responsive to inspired oxygen, to describe how VQ mismatch can contribute to hypoxemia, and then to describe the distribution of VQ in the lungs of normal people. Save you this spot right here, Jeff. So if I get tired, I'll sit down and you can stand up and continue with the lecture. So there are 4 physiologic causes of hypoxemia. And they are hypoventilation, and we'll expand in more detail on the next slide about how hypoventilation can lead to hypoxemia. So that has to do with the alveolar gas equation. Diffusion defect that we talked about 2 times ago, where there is a problem with the alveolar capillary membrane. Shunt, which we will talk about in detail today. And ventilation perfusion mismatch, which we will talk about today. There are other causes of hypoxemia which are not physiologic, such as an increase or a decrease in the inspired PO2, which can be due to altitude primarily, or a decrease in barometric pressure. So we will become hypoxemic if we fly in an unpressurized airplane or if we climb a tall mountain, because that reduces the inspired PO2, but it does not affect the physiology within the lungs. A decrease in cardiac output can cause worsening of hypoxemia, but only if there is a shunt defect that is present. So a decreased cardiac output will amplify the effects of a shunt, but if you have normal lung function, so you and I, if we have normal lung function, if our cardiac output were to decrease for some reason, that would not affect our arterial PO2. So shunt amplifies the effect, or cardiac output, the decreased cardiac output amplifies the effect of shunt, but is not a cause of hypoxemia if shunt is not present. And we will expand more upon that as we go through the presentation. So on this slide, we are going to derive the alveolar gas equation, which explains the effects of barometric pressure and FiO2 and ventilation, hypoventilation on the alveolar and then the arterial PO2. So the PO2 that we inspire is determined by FiO2 and barometric pressure. So if we breathe supplemental oxygen, that will increase the inspired PO2. If we ascend to a high altitude, that will decrease the barometric pressure and decrease the inspired PO2. However, the PO2 that presents to the alveolus is less than the PO2 which we inspire because of the addition of water vapor pressure. So as gas passes from the entrance to the airway to the alveolus, it becomes humidified, and the effect of humidification is to reduce the PO2. So the gas that is entering the alveolus has a PO2 which is determined by the effective barometric pressure. So the barometric pressure which is corrected for water vapor pressure at body temperature, not the barometric pressure itself. So there is a slight reduction in the PO2 of the gas entering the alveolus as the result of the addition of water vapor pressure. The PO2 within the alveolus, however, is less than the PO2 coming into the alveolus. And the reason for that is that the alveolus is a leaky bucket. So we're pouring oxygen into the alveolus, but at the same time that we're pouring oxygen into the alveolus, oxygen is leaking out of the alveolus into the bloodstream. So that's what gas exchange is all about, adding oxygen into the bloodstream. So then if we were to calculate the PO2 in the alveolus, we need to correct somehow for the amount of the oxygen that comes into the alveolus that is lost into the bloodstream. And conveniently we can do that because we know that the same time that oxygen is leaving the alveolus, carbon dioxide is being added to the alveolus. And we know the relationship between the oxygen leaving the alveolus and the carbon dioxide being added to the alveolus because that is R, the respiratory quotient, which says that the respiratory quotient is the difference between carbon dioxide that is taken up by the lungs and oxygen that is lost from the lung. So we can then use the known value of the respiratory quotient in order to correct for the amount of alveolus, or the amount of oxygen that leaves the alveolus into the bloodstream. And in that way we can calculate the alveolar PO2. And everybody knows that the respiratory quotient is 0.8, right? So then the alveolar PO2 is going to be the amount of oxygen that goes into the alveolus minus the amount of oxygen that is lost from the alveolus. This is the amount of oxygen that goes into the alveolus. The amount of oxygen that leaves the alveolus is the PCO2 divided by the respiratory quotient, or 0.8. So then the alveolar PO2 is equal to the FiO2 times the effective barometric pressure minus 1.25 times the PCO2, because if you take 0.8 and you divide it into 1, you get 1.25. So you can either calculate this correction by dividing the PCO2 by 0.8, which, for me at least, is more difficult than multiplying the PCO2 times 1.25. So then the alveolar PO2 is determined by the FiO2, the barometric pressure, and the PCO2. So if the PCO2 goes up, the alveolar PO2 goes down. And then the arterial PO2 will go down as well, because the arterial PO2 can never be greater than the alveolar PO2, unless you have chloroplasts to make your own oxygen, and I don't see any green people in the room, so probably unlikely that you're making your own oxygen. So the alveolar PO2 is always greater than the arterial PO2. If the PCO2 goes up, then the alveolar PO2 goes down, and the arterial PO2 will go down. So that is illustrated then on this slide. The arterial PO2 can never be greater than the alveolar PO2. Breathing room air, the difference between the alveolar and the arterial PO2 is about 5 to 10 millimeters of mercury. So if you go through the math from this slide, if you calculate your alveolar PO2, it's about 100. But if we were to draw blood gas on you and measure your arterial PO2, it would be about 90 or 95. So normally the difference between alveolar and arterial PO2 is about 5 to 10 millimeters of mercury. Hypoventilation decreases the alveolar PO2 and hence the arterial PO2, because the arterial PO2 can never be greater than the alveolar PO2. So if your PCO2 increases to 80, so let's say that unfortunately you take an opioid and that reduces your ventilation and your PCO2 goes up to 80, the alveolar PO2 and hence the arterial PO2 cannot be greater than 50 millimeters of mercury. And if you don't believe me, do the math yourself. Hopefully I did the math correctly. I think I did. So the alveolar PO2 will be about 50 if your PCO2 goes to 80 and you're breathing room air and barometric pressure is 760. Under hyperbaric conditions of 3 atmospheres, now the alveolar PO2 and hence the arterial PO2, if you have normal lungs, will be greater than 2,000 millimeters of mercury if you breathe 100% oxygen. Again, you're welcome to check me on the math if you want, but breathing 3 atmospheres, it would be, the barometric pressure would be 760 times 3. FiO2 would be 1, breathing 100% oxygen, and if your PCO2 is 40, it calculates out to be more than 2,000 millimeters of mercury. I think it's around 2,100 millimeters of mercury. So then, normally what will happen is the inspired PO2 at sea level, breathing room air, will be about 150. That will drop down to about 100 under normal conditions, just based upon the alveolar gas equation. And then the PO2 in the tissues drops down to about 40 millimeters of mercury or so, essentially what is the PO2 in the mixed venous blood. However, with hypoventilation, as a result of the alveolar gas equation, that will result in a lower alveolar PO2, a lower arterial PO2, and that could result in tissue hypoxia. Now, just for completion, I put one slide in about diffusion limitation as a cause of hypoxemia. So we just illustrated how hypoventilation is a cause of hypoxemia. The second thing on my list was diffusion defect. We had talked about that a few months ago in the second presentation in the series. Diffusion defect is an unusual cause for hypoxemia at rest. So you need to have a very severely deranged, a very low DLCO in order for DLCO to cause hypoxemia at rest. However, diffusion defect, a low diffusing defect can cause hypoxemia. So in persons with diseases like COPD and IPF who have low diffusing capacities, that can result in hypoxemia if it is combined with a low inspired oxygen, such as at altitude. So an individual with COPD or IPF with a low diffusing capacity might not be hypoxemic in Boston, but they may become hypoxemic in Denver or Salt Lake City, where the inspired PO2 is lower. In diseases creating a low alveolar PO2, so for example, the COPD patient who gets a pneumonia, and if there is an increase in pulmonary blood flow, such as with exercise or other causes of an increase in cardiac output. So individuals with COPD and IPF may be mildly hypoxemic at rest, but they may become severely hypoxemic during exercise because of the low DLCO. So this is, again, a different way of illustrating PO2 changes from the air, the gas that is inspired, to the PO2 that the tissues see. So again, the inspired PO2 Breathing room air at sea level is about 150, drops down to about 100 as a result of the alveolar gas equation, may drop a couple of millimeters of mercury actually within measurement error of PO2 due to diffusion. And then we all have a small shunt, which may drop it a few more millimeters, so that then there is a gradient between the alveolar PO2 and the arterial PO2 of about 5 to 10 millimeters of mercury, as I pointed out before. And normally at the site of the tissues, the PO2 is about 40 millimeters of mercury. So there's about 40 millimeters of mercury, PO2, driving oxygen into the cell to the mitochondria where the action occurs. So next I wanted to talk about shunt as a cause of hypoxemia. And we have a series of slides here to talk about shunt as a cause of hypoxemia. So shunt, by definition, is any blood flow that goes from the right side of the heart to the left side of the heart without participating in gas exchange. So it is the opposite, if you would, of dead space. So shunt is blood flow without ventilation. So gas is shunted from the right side of the heart to the left side of the heart without participating in gas exchange. And it is possible to calculate the amount of shunt, the QSQT, if we know the arterial oxygen content, arterial blood gas, mixed venous oxygen content, mixed venous blood gas, blood sample drawn from the pulmonary artery, and then we can calculate the pulmonary capillary oxygen content by assuming that the characteristics of the blood leaving the alveolus are the same as what occurs at the alveolus. So from the alveolar gas equation, we can calculate the alveolar PO2 and hence the pulmonary capillary oxygen content. And back in the day, when patients with ARDS and critically ill patients were managed with pulmonary artery pressures or pulmonary artery catheters, I can recall quite commonly calculating shunts. And we used to do peak titrations, where with every step in the peak titration, we would draw an arterial blood gas, we would draw a mixed venous blood gas, and we would calculate the shunt. And Bob is shaking his head because he probably remembers that as well. And so we would draw our arterial and our mixed venous blood gas, and then we would take out our slide rules and we would calculate the shunt fraction. That sounds silly, but I can recall doing that with my little yellow Pickering metal slide rule. In fact, a little anecdote, where I worked before I came here, I did some programming, and I programmed the ICU computers to calculate shunts and other things. And everybody just thought that was so great because they no longer had to use their slide rules to calculate the shunt fraction, which half of the time got calculated incorrectly. So shunt is of two types. So normally what happens is the blood flows past ventilated alveoli. We can have blood which flows from the right side of the heart to the left side of the heart and bypasses the lungs completely. And that is called an anatomic shunt. Normally, actually we all have anatomic shunt as a result of blood from the bronchial veins and the coronary veins dumping into arterialized blood. So part of the reason why we all have a gradient of 5 or 10 millimeters of mercury between our alveolar PO2 and arterial PO2 is because we all have some anatomic shunt, every one of us. A common cause of an abnormal anatomic shunt is if there is a shunt in the heart, such as with a PFO. So if there is a PFO, blood will shunt from the right atrium to the left atrium, bypassing the lungs completely, the cause of anatomic shunt. Capillary shunt occurs if blood flows from the right side of the heart to the left side of the heart, but the alveoli that it passes by are not functioning. There's no ventilation within this alveolus. So that might occur with atelectasis and consolidation and pulmonary edema, where there's blood that goes past alveoli that are not being ventilated, blood flow without ventilation. So in the patients who we see who are hypoxemic, such as critically ill patients, often the shunt that we see is capillary shunt. And what we do to improve oxygenation, in addition to administering supplemental oxygen, is we try to fix these kinds of things in the lungs. But sometimes we see a patient with a PFO, and that can be more difficult to address because shunt is not very responsive to oxygen, as we'll see in a minute, maybe on the next slide.
So Dean, before you go, next time you use your antidote, some people don't know what a slide rule is. As a matter of fact, I would bet less know than less do know what a slide rule is.
So do you want to tell them what a slide rule is?
No, this is your...
So a slide rule was actually a little device that you could use to do mathematical procedures, and it was called a slide rule because it had an external part, and then there was a center part that slid back and forth, and by how you lined up the numbers on the slide rule, you could do multiplication and division and math that was more difficult to do longhand, you could do more quickly with the slide rule. And I can recall, for example, solving things like logarithms was a lot easier with the slide rule than it was if you had to look it up on the table in the back of the math book. So
it was the first calculator.
So I might be able, if you want, for fun, if I think about it, the next time I come, I'll bring an old slide rule. I was cleaning out the basement, and I came across my slide rule that I used in college. Probably 50 years ago, so it's, I don't know if I can still remember how to use it.
Do you have an abacus?
So an abacus is good for addition and subtraction, but I don't think it works for multiplication.
Probably not for calculating shunt.
Yeah, it would be difficult to do that for calculating shunts. But you could use it to add up red blood cells, you know, so. Now, one of the the problem with shunt is that it results in hypoxemia, and this slide is intended to illustrate how that happens. So, in this case, there is a 33% shunt. So, 2/3 of the blood flow is flowing past a functioning alveolus. 1/3 of the blood flow is moving from the right side of the heart to the left side of the heart without participating in gas exchange. So there's blood flow without ventilation. Now, because of the sigmoidal shape of the oxyhemoglobin dissociation curve, the result of these two gas streams mixing is not that the PO2s average. So if the PO2s average between here and here, the effect on shunt might not be that great, or the effect of shunt on hypoxemia might not be that great. However, because of the sigmoid shape of the oxyhemoglobin dissociation curve, when we mix blood from here with blood from here, we average the oxygen saturations. Actually, more specifically, the oxygen contents, but we'll say the oxygen saturations rather than the PO2. So the blood coming by this alveolus, breathing room air at sea level, will have an oxygen saturation of about 97%. The blood coming from the shunted area will have an oxygen saturation the same as the mixed venous oxygen saturation, which is normally 75%. So for you and me, we normally have an oxygen saturation of about 97% coming from functioning lung units, and any shunt contributes oxygen with the saturation the same as mixed venous blood. So if we average the saturations, and so if you take 2 parts of 97% and 1 part of 75%, if I did the math correctly, you can check me on this, the oxygen saturation comes out to 90%. and an oxygen saturation of 90% is a PO2 of about 60. So the result then of a 1/3 shunt, so if you opened up a PFO in your heart and 1/3 of your cardiac output bypasses the lungs completely, and your lungs are otherwise normal, you would expect to have a PO2 of about 60. Now, what happens if we breathe 100% oxygen? Does it help this situation? Is there much of a change in the arterial PO2 if we change this from 21% oxygen to 100% oxygen? So let's think about that. If we make this 100% oxygen, what will the oxygen saturation here be? Instead of 97, be 100. Even though the arterial PO2, the PO2 coming from here may be 600. The most that we can raise the oxygen saturation is from 97% to 100%. So the effect that we will see on the arterial PO2 will be minimal. And that is illustrated here. So now if we breathe 100% oxygen, that raises the saturation up to 100% from the normally functioning lung, 97 to 100%. Not very much. If this is still 70% oxygen saturation in the mixed venous blood, the PO2, which was 60, goes to 65. Even though breathing 100% oxygen raises the PO2 here to 600, it can't raise the oxygen saturation greater than 100%. So shunt is poorly responsive to oxygen administration. So then if you have a patient who has a PO2 of 50 and you put them on 100% oxygen and their PO2 goes to 500, do they have a shunt defect? Maybe a little bit, but it's not the predominant cause of their hypoxemia. But if they have a PO2 of 50 and you put them on 100% oxygen and PO2 goes to 55 or 60, then their predominant cause of hypoxemia is shunt. So it could cause you to, if the PO2 doesn't change very much, then you go back and you think about these kinds of things. If the PO2 goes up a lot when you administer oxygen, then we think about things like diffusion defect, we think about things like the Q mismatch, which we'll talk about next. Now, what's the effect of changing cardiac output if we have a shunt? So again, here is our example of a 33% shunt, so 2/3 of the blood flow goes past functioning alveoli. 2/3 of the blood flow is blood flow without ventilation. If the patient's cardiac output drops, the effect of dropping the cardiac output is to drop the mixed venous oxygen saturation. So instead of the mixed venous oxygen saturation being 75%, maybe now it's 60% due to the decrease in cardiac output. Now if we do our mathematical exercise again, if this saturation is 100%, and we have two parts of this, and the mixed venous saturation is 60%, we have one part of this. It results in the oxygen saturation being 87% instead of 90%, which it was before, and that corresponds to a PO2 of about 50. So then if there is a decrease in cardiac output, the effect of that is to magnify the effect of the shunt. So in patients who, such as some mechanically ventilated patients, for example, of ARDS, have a big shunt, if they drop their blood pressure, their PO2 may tank because of this effect. And then if their blood pressure is restored, there may be an improvement in their PO2 because of the effect on the mixed venous oxygen saturation.
So in the patient with a good cardiac output and a large percent shunt, how much benefit is there for us to leave them on 100% O2?
Little. Little benefit and much potential for harm.
Right.
I think you wrote an editorial about that this month, or last month.
Oh, I did? Okay.
You and Jesus.
Oh, that one. Yes,
Yeah.
yes. No, but I think that's an important thing to remember. That's an important thing to remember because we make that mistake a lot. We leave these patients sitting on high FiO2s, even if their PO2 is 60, going to 90, 80, maybe 70 or 60 may not change that PO2 at all. It may stay right there. And you're putting that patient at increased harm by that high FiO2 that you've left them on.
Yeah, there have been several studies now, observational studies. One that we published in Respiratory Care about a year ago from Mayo, and there have been a couple of others around the same time, the last couple of years, showing that patients who have unnecessarily high FiO2s have worse outcomes.
Yep.
So it's observational, not randomized controlled trial, but I think it should make us stop and consider our practice in that.
But I thought there's one of them that is a randomized trial that looked at PO2s above and below 100.
Yeah,
surgical.
Yeah, you may be correct. Oh yes, that surgery
study. And
most of those patients were not ventilated, as I recall. But yes, you are correct. Yeah. So in post-op patients, where they targeted them to a controlled FiO2 and controlled PO2 versus just letting them do whatever.
Yeah, so keeping it below approximately 100 in the treatment group, or allowing it to go whatever it wanted to in the control group. The control group had a significant increase in post-operative pulmonary complications and a strong trend, if I remember correctly, towards an increase in mortality.
And most of the patients in that study were not mechanically ventilated, so this extends
even worse if they're mechanically ventilated.
So how do you know?
How do you know which?
So someone with a PO2 of 50, I'm not really excited about weaning the oxygen.
Well, you know when they're mechanically ventilated, usually what the chest x-ray looks like and what's going on. If you drop the FiO2 and you get no change in the PO2, it's telling you got shunt.
So then it's really just a trial.
Exactly. If it's not
I think you
shunt,
have to do an N of 1, and you have to drop the FiO2 and see what happens to the oxygen.
Because if it's not shunt, as Dean's going to talk about in a second, the PO2 is going to fall on you.
And you could do it the other way. You could increase the FiO2 and look at the effect.
Right.
If there's no effect, go back to where you were and then consider dropping it.
Because you see that all the time. Patients on 60% and the PO2 is 55 and they want you to increase the FiO2. You go to 70 and it goes to 56. You go to 80 and it goes to 58.
And then 3 days later, you're still
it's a waste
stuck
of
on
time
90%
doing
oxygen.
that and putting
But I think
patients in
that's the
harm.
proper way to do it.
Oh, absolutely.
Take someone on PO2 of 55 and decreasing it to see if they...
Yeah, no, I'm saying like if you're on 100, your PO2 is 50, you have a really hard battle to fight to say I think we should wean this FiO2, even as a trial to figure out if you do have a shunt or not.
Come on, you just go to 90.
Especially in a critically
It's a
ill
tough
patient.
sell now,
Yeah,
because the
that's what I mean.
data's new. There's old data on O2 toxicity
Yeah.
that people somewhat disregarded. And even here, we had a tendency to leave everyone at 40% whether they needed it or not.
Right.
Not even 40% was confident. So there's new data and old habits die hard, but I think your persistence will.
Yeah.
So back when a couple years ago, and we did the experiment of giving the assignments a couple of times. One time in the neuro ICU, see Gloria back there, and one time in the MICU, I put patients on room air, and the nurses they just never saw anything like that. They just couldn't imagine that I would have put somebody on room air. Their oxygen sats for 96%, but they just never put anybody on room air. Okay, so next let's talk about ventilation perfusion ratio, or VQ matching and mismatching, which can be another cause of hypoxemia. So imagine that our lung is like a big stirring pot, if you would. And we are pouring oxygen molecules into the pot, and that's getting stirred around. But at the same time, as we're pouring oxygen into the lung, we're taking oxygen out of the lung because we have blood which is flowing through this compartment. So the concentration of oxygen in this unit, in this pot, in this alveolus, is going to be determined not only by how much we pour in, but how much we lose, which kind of gets back to our discussion earlier about the alveolar gas equation. So it turns out if we look at the relationship between ventilation on the gas side and perfusion on the blood side, the range is that we could have ventilation without blood flow. So we have a big plot here, so that's dead space. So here the ventilation perfusion ratio is infinity. So we have ventilation divided by 0, and if you divide by 0, you get positive infinity. At the other end of the extreme, we have shunt, which we just talked about, where we have blood flow without ventilation. So here, the ventilation perfusion ratio is 0. So if you take 0 and you divide it by any amount of blood flow, you get 0. So the range of ventilation perfusion ratios in the lungs is between 0 and infinity. 0 and infinity. Normally, where we are functioning is shown in lung unit A, where the alveolar PO2 is 100, the alveolar PCO2 is 40, and the gas leaving this unit with normal ventilation perfusion matching is similar to what is in the alveolar gas. So the PO2 leaving here is about 100, the PCO2 here is about 40. So this is normal VQ, this is one end of the extreme, VQ of 0, which is shunt, the other extreme, VQ of infinity, which is dead space. Now, as it turns out, there is something called the PO2 PCO2 diagram, which is illustrated here. And the meaning of this is that if you're breathing room air with a normal mixed venous blood gas, every alveolus in the lung, the PO2 and the PCO2 of every alveolus in the lung has to fall somewhere along this line. So in other words, if you are breathing room air, it is impossible for you to have a PO2 of 200 millimeters of mercury. It's impossible because that would put you out here somewhere, would not fall along this line. If you have a mixed venous PCO2 of 45, you cannot have an arterial PCO2 of 150. Just not possible because it doesn't fall anywhere along this line. So the PO2 and the PCO2 of every alveolus, every one of your 300 million alveoli in your lungs, needs to fall somewhere along this line. Now here's the normal point. If you are on this part of the line, that's an increasing ventilation perfusion relationship, so that is a dead space effect. If you are on this part of the lung, or your alveoli are on this part of the lung, that's a decreasing ventilation perfusion relationship, or a shunt-like effect. It's only shunt if you're down here, but here is a shunt-like effect. So normally then, where we fall is at this point with an arterial PO2 of about 100, an arterial PCO2 of about 40, so that's where you and I are functioning now. And the PO2 and PCO2 of all alveoli must fall along this line, and there are only two ways to change the line in the alveolar PO2 or PCO2. That is to increase or decrease the inspired oxygen, or increase or decrease the mixed venous point. So now let's talk about VQ matching in more detail. So VQ mismatch, if you would. So imagine that here we have two alveoli. This alveolus, this lung unit, is normal. So the oxygen saturation entering this alveolus is 75%, the mixed venous oxygen saturation. The oxygen saturation leaving this alveolus is 97%, reasons we just described previously. However, in this lung unit, there is a partial obstruction of the airway, not a complete obstruction of the airway. If there was a complete obstruction of the airway, that would make this a shunt. But there is a partial obstruction of the airway, which results in decreased ventilation of this lung unit. If we decrease the ventilation of this lung unit, the PCO2 will go up and the PO2 will go down in this lung unit. So let's imagine that the PO2 decreases in this lung unit such that the oxygen saturation only goes from 75% to 85% because of the decreased alveolar PO2 in this lung unit. So now if we average our oxygen saturations, so let's imagine, to make the math easy, it's 50% this, 50% this. Now if we average our saturations, that gives us a PO2 of about 60. So this then might be your patient with COPD, with partial obstruction of airways. This might be your patient with asthma, with partial obstruction of airways. This may be your patient with CF, with partial obstruction of airways, resulting in hypoxemia. Now, what happens if we administer 100% oxygen in this case? Well, now if we increase the FiO2, because we can get oxygen into this alveolus, the alveolar PO2 will go up. It will go up a lot. It may not go up by a perfect amount, but it will go up a lot. Certainly it will go up enough to raise the oxygen saturation from 75% to 100%, here from 75% to 100%. And you would expect that if you take this person breathing room air with a PO2 of 60, you give them 100% oxygen, their oxygen saturation will go up to 100%, and their PO2 may go up to 500. So then how can we distinguish VQ mismatch from shunt as a cause of hypoxemia? Increase the FiO2 and see if there is an appropriate increase in the PO2 and oxygen saturation. We increase the FiO2 and the saturation doesn't budge or only goes up by a tiny amount, that means there's shunt. If the PO2 goes up a lot, that means there's VQ mismatch. So that's why on our ARDS patients, we have them on 100% oxygen, their SAT's 90. Nancy takes her COPD patient, has an oxygen saturation, or PO2 of 50, an oxygen saturation of 55 or 85%, and gives them 2 liters of oxygen. Their SATs go up to 90, 92%, with only a little bit of oxygen, right? Now, what happens to the PCO2? Well, if we have VQ mismatch, the PCO2 will go up a little bit. So maybe the PCO2 leaving this alveolus, instead of being 40, is 47. So the PCO2 is in the mid-40s, perhaps, instead of being 40. However, what happens, what normally occurs if your PCO2 goes to 44 or 45? If I increase your PCO2 to 45, what are you going to do in response? You're going to breathe more, right? So it's going to stimulate you to breathe more. And that's exactly what happens. So if you increase your minute ventilation, that will lower the PCO2 in the normal alveolus. And because the relationship between CO2 content and PCO2 is linear, it's a straight line, unlike the S-shaped sigmoidal relationship of oxygen, you can lower the PCO2 and it will average out the elevation of PCO2 in other alveoli and normalize the PCO2. So we typically do not see ventilation perfusion mismatch as a result of hypercapnia, because usually what patients will do is to increase their ventilation in response to normalize the PCO2. So then here are our causes of hypoxemia that we introduced at the beginning. So hypoventilation responds, actually you can correct the hypoxemia with hypoventilation by administering oxygen, although the correct approach is to improve ventilation. So if a patient is hypoventilating, hypoxemic, if you normalize the PCO2, if you ventilate them, then their oxygen saturation should normalize. Diffusion defect responds to oxygen. Shunt does not respond to oxygen. VQ mismatch responds to oxygen. And if the cause of the hypoxemia is a decrease in the inspired oxygen, we can correct that by increasing the ambient pressure. That's what happens in an airplane. Or we can increase the inspired oxygen, which is what happens if you try to climb to the peak of Mount Everest. So it's easier on the airplane to increase the pressure, oxygen pressure in the cabin, the ambient pressure in the cabin, than to have everybody breathe oxygen. But if you're climbing to the top of the mountain, it's easier to get there with, for me, it wouldn't be easy to get there at all, but it would be easier to get there with an oxygen tank than it would be in a hyperbaric suit. Now it turns out, so we introduced the concept of VQ, and it turns out that VQ distribution in the lungs is not uniform, even in normal people. So normally there's more ventilation at the bottom of the lung than there is at the top of the lung. And we'll explain the reason for that when we talk about respiratory mechanics a couple of sections down the road. So we are all, right now, ventilating the bottom of our lungs more than the top of our lungs. There's also more blood flow to the bottom of the lungs than there is to the top of the lungs. That's gravity effect. If you compare ventilation to blood flow, VQ, it turns out that there is a lower VQ at the bottom of the lungs, so a shunt-like effect at the bottom of the lungs, and a dead space effect at the top of the lungs. So the result of that is then that alveoli near the top of the lungs are on this part of the O2-CO2 diagram. Alveoli at the bottom of the lungs are on this part of the O2-CO2 diagram. So the top of the lungs, more of a dead space effect, bottom of the lungs, more of a shunt-like effect. And the result of that is that in your lungs, there is not a uniform PO2 and PCO2. So near the top of your lungs, the PO2 is about 130 and the PCO2 is about 28. And at the bottom of the lungs, your PO2 is about 90 and your PCO2 is about 42. So there is a distribution of VQ from the bottom of the lungs to the top of the lungs, which affects the PO2 and the PCO2 within your lungs. So this also explains part of the reason why there's a gradient between the alveolar PO2 and the arterial PO2, even in normal persons. Now it's interesting to explore how this changes with prone position. So with the interest in prone positioning in patients with ARDS, and there are a number of mechanisms for the improvement of oxygenation in prone position. And on this slide, what I will illustrate is one of those. So there are multiple mechanisms, and we won't get into all of them, but we'll look at the VQ effect. So it turns out that if you go from an upright position, so this is an upright position, if you go from an upright position to a prone position, now the gradient in ventilation from the bottom of the lungs to the top of the lungs is much less. So compare that to here. Big change in ventilation, here lesser change in ventilation. Also in the prone position, there's a less steep change in blood flow from the bottom of the lungs to the top of the lungs. So compare here to here. Oop. So the result of that then is that going from the bottom of the lungs to the top of the lungs, there is a more uniform VQ matching. So instead of having this amount of VQ matching from bottom to top, now there is only this amount of VQ mismatch, so more uniform VQ from the bottom of the lungs to the top of the lungs, which is one of the reasons for improvement in oxygenation in the prone position. There are other reasons such as recruitment of alveoli and so forth, and we'll save that for another time. So in summary then, there are 4 physiologic causes of hypoxemia. So hypoventilation, diffusion defect, shunt, VQ mismatch. Shunt is unresponsive to oxygen administration, and VQ is highest at the top of the lungs and it's lowest at the bottom of the lungs. So I think that is all I brought for this time. Questions? Comments? Yeah.
In a nutshell, is proning worth it?
Pardon?
Is proning worth it?
Okay, so, yes and no. So I will give you my take on prone, and then others are welcome to share their take. I think that in a patient where there is otherwise no contraindication to prone, if we have sufficiently titrated PEEP, and we've gotten the most that we can get out of a good PEEP titration, and if the patient remains hypoxemic, I would say that would be a PO2 to FiO2 ratio less than 100, then prone very much may be worth it. Now there are others who would argue that we should prone early patients with ARDS. And in fact, the most recent randomized controlled study that a lot of people point to, showing a survival benefit, oxygenation improvement and survival benefit with prone, they proned patients when they had a PO2, FiO2 of 150 or less on a PEEP of 10. And I would argue that in many of those patients, if they would have patients with PF ratio of less than 150, they would have gotten them up to a PEEP of 15, 18, or 20. They probably wouldn't have had a PF ratio of less than 150 anymore. So I think that prone has a place. I'm actually part of a guidelines committee that is going to publish some guidelines about this soon. And where we came down on this is that we make a conditional recommendation for the use of prone, but doing an adequate lung recruitment and PEEP titration first.
And I think that's
Bob?
key. I mean, I think Dean said it. You should be recruiting the lung, you should be setting the PEEP properly, and if that doesn't work, then I would agree you should prone the patient. But in both cases, this should be done very quickly. I mean, the mistake that everybody makes is whether it's recruiting and setting PEEP properly or proning is waiting too long into the disease process. I mean, once you get the patient stabilized, then we should recruit and we should set PEEP. And if in a few hours we don't see the kind of change we expect, we ought to go right to proning that patient. Waiting is not going to serve the patient any benefit.
So I can tell you, so I don't know what's happened with prone around here and in MICU and so forth in the last 6 months, but when the paper came out in the New England Journal a couple of years ago, 3 years ago now probably,
Yeah, maybe longer.
showing a benefit for prone in patients with ARDS in regards to survival, I expected that we were going to be proning a lot more patients. And after 6 or 8 months or so, it occurred to me, proned hardly anybody since that paper came out. And we're not proning patients any more than we ever did before. And then it occurred to me that the difference is that take patients with severe ARDS in the MICU and other units around the house, and they'd be on 18, 20, 22 of PEEP. They wouldn't be on 10 of PEEP like was done in the study. So once they got recruited as well as they could and got their PEEP set where it should be, then all of a sudden prone gets taken off of the table.
Yeah, that's exactly the practice now in the NICU. We've proned a couple of patients the past couple of months, but more often than not, they respond to recruitment maneuver and adequate peak titration, and the proning, as you said, is no longer considered.
Yeah.
But there was one patient who did, in fact, do it that way. Recruited him, did peak titration, and it still ended up proning. And there was a change in oxygenation.
Yeah, well, there's some patients that are not recruitable.
So the other thing I think you ought to remember, if you look at that trial that Dean's talking about, that prone positioning trial, if I remember correctly, the mortality in the prone group was 16%. The mortality
That's right.
in the control group was 30 or 32%. Nobody has ever shown that kind of mortality in ARDS patients. So I believe, based on the way they manage them, the inappropriately low levels of peak, that they were recruiting patients who really weren't that sick. And I'm not saying prone hurt them, because obviously it didn't hurt them, but I'm not sure that they were dealing with the same level of ARDS that we're talking about we consider proning patients.
Yeah, one of my rules of interpreting study, a randomized control trial, is if the results are too good to be true,
They're probably too.
they're probably too good to be true.
Agreed.
Dean, how much change in blood flow do you get when you prone a patient who already has significant lung disease?
Already has what?
Significant lung disease. So our ARDS patient who we're going to prone.
Yeah.
How much of the effect do you think is attributed to change in perfusion versus recruitment?
So it's so some of it's change in DQ and some of it is recruitment. I'm trying to remember if there's. I think it's still in review. I reviewed a paper for another journal recently on oxygenation effects of prones, and it's actually done by Rob Glennie and really smart people. And they make the point that there are multiple reasons for the improvement in oxygenation, and it's probably all of them together. Now, in an individual patient, one may be more predominant than another, but they actually made a big case about the VQ matching, and that's actually where I got the idea to draw this slide the way that I did. But it's not. I certainly don't want to communicate that it's only VQ. So some of it is recruitment as well.
So you also know when we first started talking about prone positioning, people thought when we prone patients, we changed the distribution of perfusion so much so that we altered it from the normal relationship. But as Dean showed, there is a change in the slope, but you still have that same gradient that exists.
Yeah, it's probably more that how the VQ changes than the ventilation or the perfusion by itself.
Right. There's a perception that when you flip these patients, all the blood flow now goes to the anterior segments, and less damage.
No.
So that's why I wanted to bring it up.
Yeah, and in fact, it's been shown on CT studies from many years ago that when you prone patients with ARDS, what was the dorsal consolidation becomes the ventral consolidation. So which would argue for things like VQ and other things.
Well, for that, and just the change in the superimposed pressure of the heart, the great vessels,
Correct.
and the fluid being now
Right.
shifted from the dorsal to
So
the
there's
ventral
less
back and forth.
compression of the ventral lung
Right.
in a prone position.
Right, so that just opens things up when you put them. So you have a greater percentage of the lung, anterior, and as a result, that's not going to consolidate as often, so you have a greater surface area for gas exchange, and it usually improves. I mean, it's rare to see a patient prone without some improvement in oxygenation.
Okay.
Thank you,
Next
Dean.
time, I think we talk about